Good afternoon and welcome to the seminar. I'm Noreen Clark and I direct the Center for Managing Chronic Disease at the University of Michigan, and we serve as the National Program Office for the Alliance to Reduce Disparities in Diabetes. This is a very interesting webinar that we have planned for you today. And we have wonderful presenters who will participate with us in a discussion. I would like to particularly thank the Merck Company Foundation, who sponsors the Alliance to Reduce Disparities in Diabetes, and also thank them for their sponsorship of this webinar this afternoon. There's an awful lot to talk about when it comes to healthcare reform, and we're going to cram a lot of ideas into this hour and hope that the conversation will be useful and valuable to you in your work. It's wonderful that we have two people who are so well versed in health policy, the health system, and implications of healthcare reform. And they're going to give us a bipartisan perspective regarding what may be evolving as we move into the future after the elections. I'll introduce them now, and then I'll make a few remarks about the Alliance before we engage them fully in the conversation. With us today is Sara Rosenbaum. She's the Harold and Jane Hirsch Professor of Health Law and Policy and founding chair of the Department of Health Policy at George Washington University School of Public Health. Between 1993 and 1994, Sara worked for President Clinton. She's provided service, information, and assistance to 6 presidential administrations and 15 Congresses, beginning her work in 1977. She also regularly advises state governments on health policy matters. We're also delighted to I wonder if someone does not have his computer on mute, which will help us all if you do that. And we're also thrilled to have with us Dr. Gail Wilensky. Dr. Wilensky is again a distinguished expert in the arena of health policy. She directed CMS, the Medicare and Medicaid programs, from 1990 to 1992. She served in the White House as a senior health and welfare advisor to President George H.W. Bush. She's an economist, and she's a senior fellow at Project Hope. So we couldn't be in better hands for our discussion. I'd like to just outline for you, if I can get the slide to change here. How we're going to lay out the conversation. I'll give you a few words about the Alliance. We're going to ask Dr. Rosenbaum to look at the election outcome and make some predictions about health reform. And then we're going to focus in on a conversation about addressing diabetes disparities in this particular complex and challenging health reform environment. And then we'll have some time for questions and answers from you, and then we'll close with some predictions from both Sara and Gail as to what they see coming down the line. Next slide. So, about the Alliance. The Alliance is a very, very interesting initiative that is working in two parallel and integrated efforts. First of all, working at the community level in 5 communities across the U.S. Camden, New Jersey, the south side of Chicago, Dallas, Wind River Reservation in Wyoming, and Memphis, Tennessee. And community leaders in each of these areas are implementing evidence-based programs designed to reduce disparities and improve diabetes care and outcomes. And the focus is those communities, those neighborhoods, those individuals who are most burdened or at risk for diabetes. Next slide. And there are 3 dimensions of the Alliance. One is community-focused intervention. Interventions that respond to the needs and interests of vulnerable individuals and families in the community who are challenged with managing diabetes. The second is to ensure that successful efforts and successful programs are sustained in policy and practice. And the third, which is the emphasis of our conversation today, is to collaborate with stakeholders at the national through local levels to foster and nurture and encourage policy and system change that actually will reduce inequities in care and in outcomes. So one of the things that we want to do today is link the experience of these 5 communities to policy considerations, changes in policies and systems that would enable people working in difficult settings with vulnerable communities, with people at high risk for diabetes complications to manage more successfully, and to lay the background of the current challenges and the current environment in which we are all doing our work. We've asked Dr. Rosenbaum to give us a sense of what she sees happening in healthcare reform activities, particularly in this few days before, since the election. So if we could have the next slide, and Sara, we'll ask you to pick up and talk to us about health policy in the election aftermath.
Thank you very much, Dr. Clark. It's a pleasure to be with you all. There is an echo going, so I'm wondering if someone still has a mic on. Ah, good, it went away. Good afternoon, and I'm going to move with the speed of light through about 15 slides. Hopefully there will be time at the end when we have fuller discussion to amplify on some of the points I want to try and make. Next slide, please. This slide is meant to show you essentially what the 2 big benchmarks are, or goalposts going into what should be a very complicated and eventful year as the 113th Congress convenes and another round of very important health policy debate begins. So if you look at the slide, you see on one side the Affordable Care Act, health reform, and you see all of the components of health reform: Medicaid expansions, premium subsidies, the insurance mandate, the state insurance reforms, the establishment of exchanges, payment reform, quality improvement, access and public health investments, and long-term care. Those are sort of the big components of the act. And of course, payment reform really refers to, among other things, Medicare payment reform. If you look to the other side of the slide, you see deficit reduction, and you see under deficit reduction that the very components of health reform that were sort of the building blocks of health reform: the new investments, Medicaid expansion, Medicare reforms, tax changes to create premium subsidies, and certainly investment in new access points and state programs, are also the focus of deficit reduction. And of course, the challenge that lies ahead is how to find a balance so that we can move ahead on health reform and health reform implementation, which in some ways is extremely important to long-term deficit reduction in healthcare, while at the same time trying to balance the new investments against a need to raise revenue and to introduce more controls over long-term healthcare entitlement spending, healthcare being one of the great drivers at this point of the federal deficit reduction. The arrows in the middle are meant to sort of give you a sense of where things might have been. So had we, as we did, reelected the president and the Democratic Senate, you could imagine with the House of Representatives remaining in Republican hands, an effort to sort of strike a centrist point. Had the president been reelected with a Republican Congress or Governor Romney been elected with a Democratic Senate, you might have seen a little bit more pull toward deficit reduction, a little bit of pull away from some of the Affordable Care Act investments, although actually I think a number of the investments would have remained very much on the table. Had we seen Governor Romney elected along with a fully Republican Congress, the tendency might have been to pull a little bit more to the right of that, fewer of the Affordable Care Act investments remaining, and potentially more significant cuts in the underlying programs that together make up the Affordable Care Act, the tax investments, the Medicaid reforms, the Medicare reforms. So next slide, please. Here we see what the election wrought. I'm not going to spend any time on it. We see that the president won re-election, having won all the states he won in 2008 except for Indiana and North Carolina. Next slide, please. And here we see the Senate election results. There was a pickup of 2 Democratic seats, a drop of 2 Republican seats, potentially a new independent, Senator-elect King from Maine, who is expected to caucus with the Democrats, but he has actually not declared himself yet. Next slide, please. The elections meeting for health policy, again, we're talking 7 days out, so it's a little hard to say. My own sense, and I'll be very interested in what Gail has to say, and certainly the discussants, is that what we're going to see is implementation proceeding under the Affordable Care Act with some modifications possible. Medicaid expansion will continue, although maybe at a slower pace, if only because of what the Supreme Court did in June. Premium subsidies and cost-sharing assistance proceeding, although again the question is whether it will be at quite the same pace, whether Congress might scale back on premium subsidies a bit. Exchange implementation proceeding. We've seen a fair amount of activity over the past several days, which I'm sure we'll talk about. A few more states may be running their own exchanges, a number of states looking to partner, some states deciding to let the federal government come in and run what's called a federally facilitated exchange. We will certainly see payment reform and system redesign go forward. We will see primary care expansion through an expansion of the community health centers program and teaching health centers, and a continuation of the public health trust fund. At the same time, as noted, the federal programs and policies that were revised as part of the Act may be further restructured, but that restructuring, I think, will preserve the insurance expansion and market reforms that are the hallmark of the Act. So we may see action around Medicaid. We may see a fair amount of action around Medicare. Again, some on the premium subsidies, and some more action around continuation of federal funding toward ACA implementation. Next slide, please. Medicaid and Medicare, what are possible scenarios? So, of course, we're facing this so-called fiscal cliff, which has become shorthand for a series of events all set to occur around the beginning of the year, when certain tax authorities that were set to expire in 2013 reach sort of the end. These are tax cuts that were granted in the early 2000s. They were extended. Now the question is whether taxes will go up for everybody pretty much. cuts known as sequestration that were set to take effect, are set to take effect at the beginning of 2013 if Congress doesn't come up with a substitute blueprint. And then also issues related to whether or not Congress lifts the debt ceiling. So the question is, you know, if Congress is going to come up with a substitute for all of this, it's obviously going to have to think through tax policy, which I think is seen as everybody as sort of the big event on the table. What does tax policy look like going forward? Whose taxes will go up? Are we going to raise rates? Are we not going to raise rates? Are people in the higher income brackets going to pay more in taxes? And if so, how will they do so? So that we sort of park off to one side. And then the question becomes, once we decide how much revenue the country's going to raise over the next decade, what do we do to programs such as Medicaid and Medicare? Do we introduce sort of more far-reaching reforms, such as what is called a per capita cap? Do we streamline eligibility? Do we allow states more flexibility to redesign their benefits? Do we make changes in how Medicaid providers are paid? There are certain protections for safety net providers. Do we introduce changes that haven't yet been considered? Do we do some streamlining about how Medicaid operates in relation to exchanges, particularly annual enrollment periods, and new options for states to do a better job of aligning their exchange and their Medicaid markets? On the Medicare side, do we move toward what is really a more restructured Medicare program? Do we introduce the concept of premium support, which is a very significant kind of pay reform? Actually, it has a precursor in the Medicare Advantage program. Do we move further down the pathway of introducing defined contributions toward coverage rather than the sort of the older time Medicare structure? Do we maintain the current Medicare structure but get more aggressive around payment reform? Do we introduce some more payment reductions? Do we introduce higher premiums and cost sharing? And one thing I should have had on here that I didn't, do we actually raise the Medicare retirement age, the Medicare eligibility age, which is an interesting question with exchanges and exchange subsidies potentially surviving. You know, is this the time to move people who need coverage into exchanges and out of the traditional Medicare program? This can be expected to emerge as an issue. Do we introduce, as part of physician payment reform, stronger incentives to become part of more vertically integrated system models that are better at controlling overall costs, rather than just restructure physician payments? So do we try and get Medicare to function more like integrated delivery systems and sort of the modern network health insurance model? I'm getting a lot of echoing. I don't know if somebody has a mic on. Next slide, please. These are, again, possible ACA fixes as part of broader budget agreements. The assumption is that there are many glitches in the Affordable Care Act, and so would we use a budget agreement as a way to also make corrections in the Affordable Care Act in order to give states greater flexibility, more flexible implementation timelines, certain new state Medicaid expansions as a function of the Supreme Court's decision, which seem to countenance more state flexibility. The law actually is drafted doesn't have a lot of flexibility, that this is something the Secretary might do, or it's something that Congress could do as part of deficit reduction package. More state flexibility around benefits and cost sharing, more state flexibility in relation to small business exchanges, issues relating to what states can do to make small business exchange membership, i.e. shop exchange membership, more attractive to employers. So these issues are all on the table. Next slide, please. There are various legislative pathways to the grand bargain. I don't want to spend much time on this because we, quite frankly, are all sitting and waiting to see how Congress proceeds. There's a assumption that Congress might come up with some early blueprint agreements during the lame duck session, which we're about to enter, but that the serious lawmaking will begin in the winter when we have the 113th Congress. It's a very short lame duck in relation to the kinds of agreements everybody is talking about. So we might see broad outlines established, but then the real lawmaking starts in the winter time. There are sort of two basic ways that Congress writes laws. One is through a process known as reconciliation, which is a fast-track process. It's part of the Budget Control Act, and it allows Congress to move things on a more rapid pace, particularly in the Senate, which tends to be more deliberative and have more amendments. And then there's the normal legislative process, which is a more deliberative process. One needs a supermajority to pass legislation in the Senate. There's typically more room for amendments. And again, the possible use of a lame duck session to sort of grant a stay on all of the reforms that otherwise would have happened at the beginning of 2013 before Congress acts, sort of an agreement to move forward with legislation to hold up otherwise broad changes that happen that would push us over the fiscal cliff while allowing more time for debate. So we don't know. It will become clearer over the next couple of weeks how Congress and the President want to approach this very delicate dance. Next slide, please. There are, at the same time, important federal implementation issues to watch. There is the issue of federally facilitated exchanges for states that decide they don't want to operate their own exchange or don't want to operate in partnership. There are implementing regulations for these exchanges as well as implementing legislation for health insurance market reforms. All of the important market reforms that will become part of the federal insurance regulatory system all have to be put in place by states because it's states that have the primary role in regulating insurance. There are new regulations spelling out in greater detail what goes into the essential health benefit package, what it means to sell an insurance package that includes essential health benefits. So we expect implementing regulations. And these two sets of regulations, actually three sets, the insurance reforms, the federal exchanges, the essential health benefits could come as early as next week, right before the Thanksgiving break. More Medicaid eligibility regulations are expected, particularly regulations that guide states in the amount of funding they will receive under the Medicaid expansion. Hello? Can you hear me? Can you hear me?
Yes, we can hear you, Sarah. And we're getting a little crunched for time.
Yes, let me just move quickly. I'm almost done. And finally, regulations on the basic health program. Next slide, please. Again, I'm not going to spend any time on this. This is simply the makeup of state election, the results from state elections. We still have majority Republican governors and minority Democratic governors. Next slide, please. And here we see that ACA issues to watch are, again, many state Medicaid implementation issues, which we can talk about during the break, particularly how states move forward to expand eligibility, bring up payment reform in Medicaid, begin to align their Medicaid programs with the exchange market, particularly in those states that are going to be running both systems themselves. Next slide, please. This is currently a status of health reform Medicaid expansion. As you can see, there are still a number of states that have opposed the expansion, although quite frankly, I think that formal state positions really won't be known until the legislative sessions begin. We have a number of states, of course, moving ahead. Next slide, please. Of course, exchanges, this question of whether states are going to run their own exchange, partner with the federal government, or essentially request that a federally facilitated exchange be set up. what kinds of standards they're going to establish, whether they will be active purchasers, what quality performance standards will be set for plans. And next slide, please. And I believe that this is the end. These are currently the states that have set up, they have selected their benchmark packages for their essential health benefits, which states have a lot of say over. And we expect more and more states to indicate how they want their essential health benefits designed to operate, both inside and outside their exchanges. Very important role for community health advocates. And then whether or not states are going to move to establish what's known as the Basic Health Program, which is a special program that consolidates with Medicaid for low-income people, rather than having lower-income people move into exchanges, have them covered through a basic health program. So there are lots and lots of things that states are going to decide in the next number of days, and lots to talk about in the discussion period. Sorry, yeah, done.
That was an amazing overview, Sara, and was extraordinarily helpful for those of us who aren't quite as close to what's going on in Washington as you are, and really indicates how complicated this situation is, and how all of us are trying to find some clear path in our understanding as we move forward. I'd like to turn our attention now, in light of these contextual issues that you've raised, Sara, to think about possibilities for addressing diabetes. And as we go through this next section of the webinar, I'd like to encourage any of you who have questions that you would like me to raise with Sara and Gail, please use the chat box and enter your questions. We will try and get answers to you about your questions, whether or not we actually get to them in this discussion. So if I could have the next slide. One of the important things, as I mentioned earlier, that the Alliance to Reduce Disparities in Diabetes has tried to do is make a link between what's happening on the ground in communities where there are people at high risk of problems and complications from diabetes, and policy at the broader level, state and national level. And to help move the policy discussion forward, the Alliance conducted a study working with the local community sites to identify the barriers and the problems they confronted in trying to integrate care, reach high-risk populations, coordinate care. And we then convened experts from around the country who are national stakeholders in diabetes. And through an iterative process, developed with them a set of considerations that we think all of us working in diabetes need to attend to and deliberate on, and we'll do that in just a few minutes with Gail and with Sara. So let me describe to you the 6 policy considerations that are priorities for the Alliance. One category of consideration is health system needs. And 3 important dimensions of this are the greater integration of public health and healthcare systems, figuring out how these 2 systems can be more complementary, and recognizing that the level of help that people with significant diabetes problems needs cannot be totally attended to in one or the other system. So how do we encourage greater integration and make more optimum the services in these two systems. How do we share and report community-wide health data? Many information systems are health system specific. Many public health information systems are regional, but neither are particularly robust in identifying patients who are experiencing problems across patients across communities, and using those data as ways to target services and assess the success or lack thereof of interventions. And how do we eliminate incentives that actually create underinvestment in low-income, high-risk patients? And I know that's something that both Gail and Sara are interested in, and we'll talk about that in a minute or two. There was also a category of considerations that address provider, mostly clinical provider, needs and concerns. How do we make sure that accountable care organizations really have the ability and the motivation and the incentives to reduce disparities in populations where these disparities are most acute? And how do we support the deployment of community health workers? The evidence for the effectiveness of community health workers are growing, the evidence is growing daily, and yet we don't have optimum opportunity for deploying them, particularly in communities of need. And finally, addressing patient needs. How do we enhance diabetes self-management support? Not just education to families within clinics and within communities, but the support systems that undergird self-management efforts. So, if I could have the next slide. Let's talk first about health system needs and these three policy considerations. Gail, could I ask you to talk to us a little bit about this integration of public health and healthcare systems? Do you see any way that communities could utilize some of the opportunities through the Accountable Care Act to bring about greater coordination and integration of these systems?
It's not obvious to me that the way the accountable care provisions are currently legislated, that will happen. I was thinking about, as you raised that, what it would take to get the accountable care organizations to focus on reducing disparities, and the answer to me as an economist is that when the patient outcomes and quality metrics are being defined, having a reduction in disparities would become one of the metrics that would be included, maybe as a swap for something that is already there, rather than adding to the 33 metrics already in place. The real problem I see with regard to the integration question has to do with convincing a payer or a recipient of funds that they will be better financially off if they make this integration. And the biggest problem that I see at the moment, and I don't see the resolution yet in sight, is different funding streams are going for public health and for the ACO or other delivery mechanisms. It would be possible to try to get a refocus and reorientation, but the problem is making sure that the party that will have to put up money for the integration is the same party that is likely to receive the benefits. One of the major problems for those of us who are trying to encourage more integration for the dual eligibles, those who are on Medicare and Medicaid, is the states are going to have to do most of the heavy lifting, and most of the savings are likely to go to the federal government. And unless there's a way out of that bind, it is hard to get the proper motivation by the states. Some of that same problem I see existing in terms of the integration of public health and healthcare delivery. Not impossible, just a question of whether there can be a better alignment between who's paying and who receives the benefits.
Right, and I think that the theme that has thread its way through all of our policy considerations is this misalignment between the financial incentives and the actions that we need to take to improve, reduce disparities, for example, integrating public health and healthcare systems. Sara, do you have a thought about how this greater integration is possible or not?
Well, I agree completely with the paradox that Gail has outlined. That is to say that the entities themselves that are potentially being formed, that is the accountable care organizations, have to figure out a way of financially integrating themselves so that if one of the partners, the partner that's being called upon to make the investment actually reaps some of the benefits of it. And you know, the sort of the basic problem here is that once you add in specialists and hospitals who are obviously the deeper pockets, it's not clear that they would ever be the ones to benefit directly, because of course one would see a lower reliance on specialists and fewer hospital days if things were working better for people. Two other thoughts. One is that under the Public Health Trust Fund, the CDC has funded community transformation grants. It has struck me over the time period that the CDC has been doing this that there has been relatively little interaction between communities seeking community transformation grant funding and the same communities in which providers are beginning to come together to form accountable care organizations to participate in Medicare or Medicaid. And one would hope that there might be more interaction in order to bring some additional resources to jumpstart better community health management as an aligned activity with ACO formation, so that you're not asking the ACOs, at least not up front, to invest their own money in something they don't want to invest in. Sort of, you know, having public health come to ACOs and saying, we'd like to partner with you. That's one thought. The other, which we haven't talked about, is the fact that under the Affordable Care Act, there is much greater clarity around hospital community benefit investment activities. Hospitals putting on a separate hat, not their ACO hat, but their hat is not-for-profit hospitals, so this only applies to nonprofit hospitals, are expected to make community health improvement and community benefit investments. And right now, I think something like 0.5% of hospital investments are going into community health improvement. We're talking money in the billions of dollars annually, and whether hospitals might, putting on their community health improvement hats, make investments that, again, would run alongside of their ACO formation, you know, that might be a way to jumpstart some of the health worker types of activities that the coalition, I think, has correctly identified.
Those are probably some of the most at-risk dollars with deficit reduction I could think of. I don't disagree. I think it is going to be particularly challenging because of the enormous fiscal pressure that we are going to see with the 113th Congress, as Sara so clearly laid out that there is going to be a real tension between whether you go for the easily scored savings, which usually mean reduced payments to providers. Hospitals, physicians already have their own fiscal cliff in January, or drug payments, rather than trying to make the longer term less certain for savings investments to try to provide more integrated care, which should reduce costs, but not necessarily to the CBO's reckoning or in the short term. And that's going to be the terrible tension we face in the next year or two. And I think it's particularly an issue for exactly what we've just discussed now.
Let's shift our attention. We're not going to be able to touch on every one of our policy considerations, but let's shift our attention to incentives that encourage underinvestment in low-income and high-risk patients. I know both of you are very interested in this. Gail, what's your view of any safeguards that can be put into place or that are not being implemented in the moment to prevent this underinvestment in the populations that we're interested in helping?
It would be really valuable and important with all of the increased money that the federal government is about to be making, expanding Medicaid, which is clearly a very major commitment on the federal government's part, that it insisted on health outcome measures for some of these affected populations. I think that is, to my mind, a major strategy to keep from either cherry picking or skimming your focus so as to go after the easiest rather than the most challenging patients. For reasons I don't understand, the federal government historically has not done that either, especially in Medicaid, but not so much in Medicare either, unless we consider the Medicare Advantage program. So you get concerns in Medicare about whether people are being discharged too quickly after DRGs were introduced, but somehow nobody seems smart enough to ask for some measurements on the health outcomes of people being discharged. So I think, to me, providing a little more flexibility perhaps to states in exchange for better data than we have ever had, which is no data, so it's easy to get over that bar, about what happens to these particularly vulnerable populations.
Great. Sara, that outcome assessment, you think that's the direction to move in?
I certainly think that measures that hold healthcare systems and providers accountable for the actual results of their care are the way to go. I think that of course, with the Medicaid population, it's a little complicated because Medicaid beneficiaries, although that's not really true with the newly eligible population quite as much. There are high-risk people in the group, but there are also a lot of low-income workers and young families who actually are relatively healthy people. But I think that you've got to combine health outcome measures with a whole different. I mean, I am sort of a believer in a geographic approach to healthcare at this point. I think programs like community health centers, not necessarily in the specific performance, but in their design, are the way to go. That is, people should be expected to not be able to choose, providers should be expected not to be able to choose the communities they serve any longer. We should be, in fact, expecting providers to penetrate a geographic region with then broad level risk adjustment for providers that see geographic regions that show higher overall levels of health risks, higher levels of poverty. So the providers that practice in suburban areas where people tend to be healthier would get relatively lower rate of payment than providers that practice in the toughest parts of communities, whether you measure it by county or preferably by census tract, something that says we hold you accountable for the residents of a region, as opposed to we hold you accountable for the patients you select. I think as long as we incentivize people to select their patients, even with health outcomes, it's very hard to move us to where we need to be. And feeling that sense of obligation to your geographic community is sort of where we want to move the payment system over time. And then you would begin to see changes.
Great. Thanks very much. Let's see the next slide and pick up on a point that many are interested in, particularly groups that are working in low-income communities. Gail, do you see any opportunities for reimbursing the services of healthcare workers like community health workers through Medicaid or any of the other options that could come available through the Affordable Care Act provisions?
You could. The question, to my mind, will be whether or not, well, there are going to be two challenges that will get raised. The first is whether or not the payer can be convinced with credible evidence that doing that will lower the cost of the individuals they're responsible for anyways under Medicaid. I could see it much easier in a community health center. I support a lot of what Sara Rosenbaum has raised, particularly for population basis rather than at a selected patient enrollment basis. The question is whether or not the people who are paying, which for the first 3 years government, will become convinced to, one, allow this to happen, and two, whether or not they will be, whether the government will survey those who are closer to the actual delivery governments to engage in activities that would reduce. Again, to me, it's going to be facilitated by having a broader payment rather than individual micro payment streams, but also by rewarding better health outcomes for particularly difficult. On its own, it's not likely to happen.
Okay. So, Sara, what are your views on this, the community health worker and new forms of workers who are more connected to communities that are vulnerable?
Well, of course, this is an idea. If you go back and read Jack Geiger's writings from the time that he was in Palela, studying what the Karks did in establishing what became, of course, the prototype for what we now know today as community health centers, the notion of a community health worker is so intrinsic to this model of care, whether it's clinically based or working with physician practices. I mean, you don't necessarily have to have a community health center to make this work. You could have a health department providing community health workers to medical practices as sort of a practice support activity. Certainly Medicaid managed care organizations can, and some do, provide community health workers. Many of the models that states are talking about now in their redesign for dual enrollees contemplates people whose job is really not just to connect patients with health care, but to connect patients with health. And I think to me, the issue is anybody, it's the point that Gail has been making, is anybody willing to capitalize this, since there's an upfront investment that needs to be made? And then to the extent that savings are realized, are systems allowed to capture those savings? And are they allowed to capture those savings and basically with an expectation that they're going to plow some of those savings back into community health workers? It's the kind of thing that a payer with careful attention to the design of the payment mechanisms could build into contractual expectations. And, I think we're ready for a new round of technical tools to help payers think about how to do this. We want to share savings with you, and we're willing to let you have some of your savings to plow back into bonuses for physicians and high-level executives, but we want some of that money to go back into community health workers for lots of reasons. So it's really, what do payers expect, and how willing are they to say this is what they expect?
So that brings us to the next slide, if I may have it. And one of our policy considerations related to patients' needs and the way to enhance self-management supports. I know that in many communities, in many community settings and clinic settings, community health workers are seen as a way to create support for people in managing their own conditions. But Gail, do you see any way in which a consistent kind of core set of self-management support services could be included in some of the essential benefits packages that are likely to be considered over the next few years?
No. You want to know my honest opinion, again, because the pressure is going to be so great on trying to spending required to implement the legislation from growing. I believe that what could occur, however, if there is compelling and convincing evidence that self-management of diabetes by the patients reduce further complications and therefore further healthcare expenditures, you can have ACOs or integrated deliveries or other groups that may begin to be at risks for the patient's care being willing to encourage and provide some support for the self-management. It is going to require two things to happen. First, credible evidence that self-management really does reduce further complications and costs in the short term, say the year following the onset of this activity, and that there is a group that is at risk for the downstream, short-term downstream spending that would otherwise occur. To the extent we see in the Medicaid expansion, even more emphasis than we have already seen on Medicare managed care, or you see the growth in global capitated payments or on at-risk groups for the non-Medicaid population, and you have the credible evidence to support the patient self-management, you then potentially have a party who would be willing to initiate this activity. Getting extra money going forward for almost anything even if it has reasonable long-term payoffs, is going to be exceedingly difficult.
Wow, so evidence, but evidence that makes itself known in benefit in the short term. Very interesting. Sara, do you have anything to add to how we can create more self-management support? Is
So,
funding there for?
two very quick thoughts. The first is that I think this is an area where, quite frankly, in addition to the very important point that Gail made about having evidence to support this investment, I think that we just got to think about, this is where mobile technology, I think, can really make a difference, at least for those patients who are adept at and capable of using and interested in mobile technology and various kinds of online support systems and social networking that can make a difference for people, connect them with a broader world, and let them get support groups through ways other than the very expensive face-to-face investment. Now, on the face-to-face investment, as somebody who's spent a long time representing families, both families with and families without a very high health burden, my assumption is that within the world of people who have diabetes or diabetes risk, we still have many, many levels of risk. And within the world of people who are at risk, there is a core of people whose risks are so high that only intensive face-to-face investments will help. And there I am most interested, actually, in what New York State is proposing to do, which is quite a grand proposal. But essentially what they're asking is that a portion of their anticipated savings from Medicaid system redesign be invested in supported housing. I think there are people who don't simply need the caseworker coming to the door once a week or talking to them every few days. They need to live in an environment that's very supportive, it's not a nursing home environment, it's not a healthcare environment. They need to live in housing where being healthy and being supported is just built into the housing arrangement. And until we get to that discussion, I'm not sure that anything other than the most intensive face-to-face casework really will do the trick. But that there are a lot of people who might be helped with technology, and we haven't even begun to think about that yet.
Great, wonderful ideas. So, Gail, would you be willing, we have only time for one question, alas, but for those of you who've sent in questions, we will try and get responses to you. Could I have the next slide, please? And this question is very much a predicting question. May I have the next slide? So, Gail, what elements of healthcare reform do you think are going to receive the most attention or the quickest attention? There are a lot of elements, but if you were a betting person, where would you place your bets, and why do you think that particular element would rise to the top of the agenda?
One of the issues that's going to need to be resolved quickly is whether the administration will allow partial Medicaid expansions. That is, for some of the states who are most reluctant to pursue either because they don't trust the federal government to come through with 100%, or they're uneasy about the 90% that it will fall back to after 2016, whether they would be allowed to go to full poverty line, which will then permit the state residents to at least be able to get subsidies and exchanges to buy health insurance in their state or federal exchange. There are going to be a series of decisions that Sara outlined well early on about can states be ready on time, if not, how will the federal government backstop? And there will be a second set of questions about whether there will be any slippage considered either in the implementation schedule because of difficulties in states being, or because of the budget attractions, or not. And this will be part of that, if not grand fiscal bargain, which I'm not sure I believe in, but it will be part of the larger package of how do we try to back ourselves off of the fiscal cliff that we.
Well, Sara started us out and had the first word, so Gail will leave you with that very concise and enlightened view of how we can pull ourselves back from the cliff, and give you the last word. And give both of you our sincerest thanks for taking part in this webinar. And if I could have the next slide, please. I'd like to call the attention of all in the audience to the opportunity to see the full policy considerations document and executive summary from the Alliance. You should see on your screen now the link, the www.allianceforddiabetes.org. We think it should be very helpful to you in your work and forming your opinions and your directions of support and query, and your efforts to help reduce these alarming disparities that we see in diabetes. Again, thanks so much to Dr. Gail Wilensky and Dr. Sara Rosenbaum for a really wonderful discussion of the immediate aftermath of the elections and the current possibilities and challenges in diabetes disparity reduction given healthcare reform. And thanks very much to all of you in the audience for joining us today.